Good morning, everyone. Welcome once again to our UCT-African Wednesday meeting. I'm Dr. Charles Moyo, and today I'm going to be presenting a common topic, head and neck cancer of unknown primary. Just a few house rules as a reminder. Don't forget to mute your microphones every time you log into the meeting. And if you've got any question, you can either use the chat function or the raise hand function at the end of the presentation. Without further ado, I'll go on to my talk. I have no disclosures, and basically the aims of this presentation, I'm hoping by the end of this presentation we may be able to answer all these questions. And the aims are basically to determine what is the appropriate preoperative evaluation for patients with a neck mass suspicious of malignancy, and what are the appropriate surgical diagnostic and therapeutic procedures for squamous cell carcinoma of unknown primary, and what are the treatment considerations and appropriate techniques for surgical management of the neck. And we will also try and define the treatment considerations for radiotherapy and also systemic therapy in squamous cell carcinoma of unknown primary. Adopted these questions from the American Society of Clinical Oncology 2020 guidelines. So squamous cell carcinoma of unknown origin, of truly unknown primary is a quite rare entity, and it often presents as a painless enlarging neck mass. And in most cases, the primary tumor is identified due to the improved diagnostic techniques, as we shall see later, due to the use of cross-sectional imaging, molecular diagnostics, robotics, and PET scanning. This has actually improved the detection rates to up to more than 90% of cases, making this squamous cell carcinoma of unknown primary origin quite rare. If you look at the definition, primary metastatic squamous cell cancer of unknown origin is defined as a malignant neoplasm, which is metastatic to cervical lymph nodes without an identifiable primary tumor following a comprehensive evaluation. By comprehensive evaluation, meaning proper history and physical examination, pan-endoscopy, and cross-sectional imaging. So you should note that these lymph nodes should not be isolated to the supraclavicular region, as cancer of the skin and infraclavicular primary sites also metastasize to this group of lymph nodes. For example, lung, breast, colon, esophagus, prostate, cervix, ureter, and as well as lymphoma. If we look at the epidemiology, the incidence of metastatic squamous cell cancer of unknown origin is about 1 to 4% of all head and neck malignancies, and more than 90% of cases are squamous cell carcinoma, the remaining 10% being adenocarcinoma, melanomas, lymphomas, undifferentiated carcinomas, etc. And the most common site is the oropharynx, and with the HPV-related oropharyngeal tumors being the most common entity. If you look at the hypothesis, or sort of like the reason why we may fail to detect the primary tumor, it can either be due to a small size tumor. Usually tumors less than 5 millimeters can be missed by conventional cross-sectional imaging, or even physical examination or a pan-endoscopic examination. Again, it can be due to the fact that the tumor may regress due to either the patient's immunity, or if the patient has a previous radiation. Again, you may miss slow-growing tumors, which can later, which later you can then pick up the primary, or this can be due to the hidden location of the primary tumor. For example, if the tumor is in the chancellor crypts, or if it's a cutaneous tumor and you don't perform a proper sort of like a skin examination, or previously resected skin nodules that you can actually miss. Or it can be tumor located outside the head and neck region, as I alluded to previously. If we look at the etiology of cancer of unknown origin is more or less the same as the etiology of other head and neck squamous cell carcinomas. that have defined primary origin, with tobacco and alcohol use being high on the list, and betonage chewing also predisposing to oropharyngeal primary site, plumber Vinson predisposing, plumber Vinson being a risk factor for esophageal cancer, and other potential risk factors like HPV for your oropharyngeal tumors, poor oral hygiene, gastroesophageal reflux disease, and as well as malnutrition. And then if you look at the nasopharynx, EPV is also a part of the risk factors, and other environmental factors may also play a role, like nitrosamine exposure, nickel exposure, wood dust, and exposure to polycyclic hydrocarbons. And if you look at the sinonasal malignancies, and nickel wood dust also come into play, and thorough-dust exposure, this is a contrast agent. It's also a risk. You pose the risk of sinonasal malignancies. And then you also you've got risk factors for cutaneous malignancies like UV light exposure, and patients who are at risk, for example, patients with genetic disorders like xeroderma pigmentosum, which is a defect in your DNA repair. So the next step is we will try and look at how to approach a patient with a head and neck cancer of unknown primary. So you should take note that the selected course of action should be considered by the treating provider in the context of treating the individual patient. And many times when you evaluate these patients, you want to assess sort of like which resources are at your disposal. Is there surgical expertise to perform some of the procedures like a neck dissection? Do you have access to endoscopic equipment or pan-endoscopic equipment? Do you have access to radiotherapy? Because this has got a bearing in terms of how you wake up your patient. So, for example, this is just an example of the hospital where I started my surgical training, where we don't have, we hardly have radiotherapy resources. We couldn't perform pan-endoscopies. We didn't have access to TrueCut biopsies, and we only had one cytopathologist and to cover the whole, sort of the whole province. So you find that in this case instances, usually when we found patients with sort of huge neck nodes, what we did was open incisional biopsies, and then we send them to the radiotherapy department without even performing a pan-endoscopy or without doing any imaging, because we didn't have any CT scan. So this sort of like gives a perspective in terms of how you approach a patient and how you wake up a patient, depending on the resources that are at your disposal. In terms of clinical presentation, these patients usually present with a painless neck mass, which is usually present for more than 2 weeks without signs and symptoms of inflammation or infection. Typically in patients above the age of 40 years who present with a painless cystic or solid neck mass, they warrant a proper examination to exclude malignancy. And if you look at your history, you can sort of like pick up some of the symptoms which may give you an index of suspicion of where the possible primary source could be. For example, in patients with otalgia or oral fullness, the possible source could be the pharynx, the larynx, the nasopharynx, or the ear. Patients who present with otorhinolaryngal dysphagia makes the likely source to be either pharynx, esophagus, or oral cavity. So basically, your symptoms should guide your physical examination and your investigations. And then, in terms of the physical examination, we should perform a comprehensive head and neck examination. Always examine the scalp and also the non-hair-bearing skin for any previous scars. Often, at times, these patients present, they have a history of some nodule excised from the skin and actually being never sent for any histopathological examination. So you should also take note of scars in non-hair-bearing areas. Your examination should also include inspection and palpation. You should always palpate the skin for subcutaneous nodules and always palpate the floor of mouth so that you don't miss any suspicious lesions. And then you will then perform your fiber optic nasal endoscopy plus or minus indirect endoscopy, and you always examine all your lymph node levels. But this is the lymph node drainage is also appearing in terms of your primary tumor focus. So while it's performing a nasal endoscopy, you should pay particular attention to sites where a small primary focus may be missed. For particular attention should be paid to the nasopharynx, to the base of tongue, to the infrahyoid epiglottis, and the piriform sinus. And sort of a modification of our conventional fiber optic nasal endoscopy is the use of the narrow-band imaging. So this is basically a modification of the standard white light that we use for our flexible nasal endoscopes. This standard white light is filtered into a narrow band light of 2 wavelengths, that is 415 nanometers and 540 nanometers. The basis of the narrow band imaging is that the lights of shorter wavelength, they basically penetrate the superficial mucosal layer, giving a brownish color of the submucosal vasculature. And the lights of longer wavelengths will give you a sort of a different subcolor, a different color the deeper you go in terms of your mucosa. So the 540 nanometer wavelength will penetrate the submucosal layer. Apologies for this, there's a spelling error there. And it will sort of like give a cyan color of your submucosal vessels. So this is basically what I was describing, that the narrowband imaging basically uses a filter of the white light, and you end up with 2 bands of light of 415 and 540 nanometer wavelength. And then there's color adjustment due to the reflection of your mucosal submucosal vessels, giving you the images that you see. So the capillaries on the mucosal surface will give you a brown image, and the deeper you go into your submucosal vessels, you get a cyan images. So this is just an example of the use of narrowband images. This is just normal mucosa. As you can see, the smaller vessels are the most superficial vessels, and the deeper ones, the larger vessels, are the submucosal vessels. So as you can see in this other picture, you can clearly see the more superficial vasculature appears brown, and the more deeper vasculature appears cyan in color. So the principle behind this is that, as we know that tumors or carcinogenesis involves angiogenesis and neovascularization, so you expect a more dense network of vasculature in areas which are suspicious of malignancies. This is just an example of a tumor on the vallecula, which was missed by conventional panendoscopy and cross-sectional imaging. And it was actually, you can clearly see on the narrowband image that there is definitely submucosal lesion. So in this systematic review, which was published in 2019, and the meta-analysis actually revealed the overall primary detection rate of about 35% of narrowband imaging after a standard wake-up and cross-sectional imaging. That is, after your complete physical examination, panendoscopy, and negative imaging, it has a wake-up rate of about 35%. And again, as I alluded previously, you need to perform a complete nodal examination. You examine for all lymph nodes. And as we know, if we look at the drainage system of the head and neck, this can sort of like give you an index of suspicion of where the primary site can be. For example, if you've got parotid nodes, you need to suspect your primary is either scalp or salivary gland tumor, that is the parotid, or even conjunctiva tumors, they also metastasize to the carotids. The most common sites of involvement in cancer of unknown primary is level 2 or level 3, which drain basically the transfer the oropharynx, larynx, and also the mouth. So it is actually important that you take note of where the metastatic node is located, so that it gives you an index of suspicion to where possibly the primary site would be. And after a physical examination, you want to determine the pathology by a biopsy. You can do FNA. The pitfall with FNA is that at times you may fail to perform molecular testing, and which we usually end up doing a core needle biopsy for these patients. However, if you don't have access to core needle biopsy, you can perform a surgical biopsy. But of note is that if you're taking these patients data for a surgical biopsy, you may as well consent them for a neck dissection. And of late, we've seen the use of molecular testing, that is your P16 for your HPV positive oropharyngeal carcinomas, EPV pointing most likely to your nasopharyngeal carcinomas. And then depending on your, depending on your index of suspicion, you may order other molecular testing or tumor markers, for example, thyroglobulin for the thyroid malignancies, calcitonin for medullary thyroid carcinomas, thyroid transcription factor, as well as PX there for either thyroid malignancies or thymic or uterine tumors. And then if we look at imaging, again, you should take note of the resources at your disposal. I understand not all head and neck surgeons, or not all of us will have access to CT scans, MRI scans, or PET scans. At times, it is actually prudent to just perform a single chest X-ray to exclude any chest metastasis. But the CT scan, in contrast, is usually the first line of the imaging modality. And MRI scan, in contrast, is also indicated in some cases. So you want to order a CT scan head and neck, chest, abdomen, pelvis is indicated. That is after your complete physical examination. And again, we employ this law that I adopted from Prof. That this law of diminishing returns with an additional cost with more than one imaging modality. And again, of recent, there's use of PET scanning. However, this should not be your first line. This should not be your first line imaging modality, because this also comes with its pitfalls. One, it is quite an expensive investigation, and you know, we can't sort of like access a PET CT scan always. I'm sure in other centers, you know, we don't get access to a PET CT scan. But you should note that PET CT scanning is only useful if performed prior to endoscopy, because you may get false positives if there is either prior biopsy, or you can get a false positive in salivary glands and in lymphoid tissue, and it also miss sub-centimeter lesions. This is just an example of a PET scan and a PET CT scan. As you can see, a PET scan can really just show you areas of uptake and doesn't necessarily delineate the anatomy and the site where there is increased uptake. So this is the benefit of the PET CT, that it can actually show you the area of uptake in the anatomical location of increased uptake. Again, Lihong and New in this meta-analysis demonstrated that the use of an FDG PET CT scan has a sensitivity of about 44%. That is due to the associated false positive, and the high specificity of 97% in actually detecting the primary in patients with the cancer of unknown primary. So they concluded that this investigation is particularly has got a high specificity and low sensitivity for detecting the primary site in patients with the cancer of unknown or primary. Again, in this review by Navimani et al. That was published in 2015, they also concluded that the PET-CT scan is a valuable diagnostic tool in locating head and neck cancer of unknown primary. It also helps direct the biopsies and locates local and distant metastasis, and can also help to locate asynchronous tumors. But however, due to the fact that in some patients who had a negative physical examination, a negative cross-sectional images with a negative PET-CT, they found a positive lingual tonsillar biopsies, and therefore they concluded that pan-endoscopy and biopsy remains an essential adjunct to your workup, irrespective of the PET-CT results. This brings another interesting discussion that is PET-CT really necessary, or is performing a CT scan really necessary if it's not going to change your management. And again, this brings us to rigid endoscopic guided biopsy of the nasopharynx. So blind biopsies of the nasopharynx have been proven to be unsatisfactory, and they often yield a poor yield. They often provide a poor yield of primary site diagnosis. And the recommendation is that biopsies should be guided by rigid telescopes, especially where abnormalities have been noted on imaging, either using a contrasted CT scan or a PET CT scan. Otherwise, they are unlikely to yield any positive results with the negative imaging. And again, if you look at bilateral tonsillectomies, this is recommended when the primary is not obvious from rigid endoscopy. And the rationale behind use of bilateral tonsillectomies is that evidence has shown that the primary resides in the contralateral tonsil in up to 10% of cases, and it reduces the need for irradiating the contralateral neck. And due to the fact again that the HPV disease may be multifocal, in some instances, the primary has been picked up in the contralateral tonsil, and again, it gives you a better image on the subsequent physical examination in terms of your patient follow-up. And although some argue that it's associated with more or complications, it has been shown that bilateral tonsillectomy actually has minimal complications. But this is a debatable area, as well as some still advocate for unilateral tonsillectomies with acceptable survival outcomes. So if you look at this systematic review in meta-analysis, which was published in 2018, they looked at 14 studies which met the inclusion criteria and included 673 patients. And of those patients, about 140, which is about 21%, had occult tonsillar malignancies, and about 89% of those were ipsilateral, with about 1% being picked up on the contralateral tonsil, and with about 10% having synchronous bilateral tumors. And the meta-analysis of level studies showed an overall detection rate of about 0.34% for a bilateral tonsillectomy. So in their conclusion, they concluded that palatine tonsillectomy is a valuable diagnostic tool in the management of squamous cell carcinoma of unknown primary, and you should consider bilateral tonsillectomy if possible. Again, in this retrospective cohort, they looked at the role of the tonsillectomy in management of cancer of unknown primary with the P16 analysis. So in this retrospective cohort, their rates of primary detection after bilateral tonsillectomies and testing for HPV was the rate of primary detection was about 59% for P16 positive tumors, and it was 0% for the P16 negative tumors. So they concluded that you should consider bilateral tonsillectomies with or without a mucosectomy of the base of tongue in squamous cell carcinoma of unknown origin, P16 positive patients, but not in P16 negative patients. Again, if we look at tongue-based biopsies, blind biopsies have been shown to be unsatisfactory, and it is either advisable to take deep base of tongue biopsies. And with the current use of transoral robotic techniques, this has actually led to base of tongue mucosectomy, which samples the entire base of tongue, because it has been shown to identify the primary in more than 50% of cases after a negative PET CT and a negative tonsillectomy. And we should also take note that the primary in the base of tongue as well, the primary may be contralateral in up to 10% of the cases, bringing a question of either, shall we do a unilateral base of tongue mucosectomy, or shall we do a bilateral base of tongue mucosectomy, taking into consideration the complications associated with a complete base of tongue mucosectomy, like bleeding, dysphagia, and pharyngeal stenosis. And again, if we look at this systematic review, they looked at the role of transoral robotic surgery and transoral laser microsurgery and liver tonsillectomy in the identification of head and neck squamous cell carcinoma of unknown primary origin. This was published in 2016. So in the result, they showed that either transoral robotic or transoral laser microsurgery identified the primary tumor in 80% overall, and in 67% of patients with unremarkable findings of makeup, that is after a complete physical examination and cross-sectional imaging. And lingual tonsillectomy using these techniques identified the primary in 72% of cases after a negative cross-sectional imaging and physical examination. And there was about 5% hemorrhage rates, which was the most common complication noted. So in conclusion, they concluded that lingual tonsillectomy using the new approaches such as the transoral robotic surgery or transoral laser microsurgery may improve the identification of focal primary tumors. However, taking into consideration that some of these resources are not disposable to other centers. And then the next section will look at the management of cancer of unknown primary. So this largely involves a sort of like combined head and neck meetings, and in most instances, the head and neck tumor board involving the ENT surgeons, the oncologists, radiotherapists, maxillofacial surgeons, etc. And in most instances, as I have alluded previously, it involves multidisciplinary tumor boards. And however, this still generates a lot of controversies. And patient management is largely based on institutional protocols, which can either be a curative or palliative intent, depending on the stage of your cancer. And you also need, it also depends on the general fitness of a patient to either undergo surgery or chemoride deletion, and the ability to deal with the consequences of the treatment. But in general, the management can be categorized into early disease, which is amenable to single modality treatment, and advanced disease, which is amenable to multi-modality treatment. I didn't include the staging. You can look up the staging on the HACC 8 or UICC cancer staging guidelines. But what is important is that for you to stage these tumors, you need to have a confirmed histological diagnosis. And after a complete workup of your patient, there is no evidence of primary tumor. That is only and only when you can then classify your patient into having a cancer of unknown primary. And so if your patient is P16 positive, the staging, your patient is staged under a P16 positive oropharyngeal classification, and EPV positive cases are staged under nasopharyngeal classification. So the classification for the cancer of unknown, proper cancer of unknown primarily includes is for the P16 negative and EPV negative tumors, taking into consideration that some of these policies, they basically do not apply in our African settings, because about only 1 out of the 17 head and neck surgeons in Africa have access to P16. So you should take that into consideration when you are managing these patients. And then in terms of managing the resectable neck, most units, they favor either radical or modified radical neck dissection with adjuvant radiotherapy for multinodal neck disease and chemo radiation for extra nodal extension. And the rationale behind a primary neck dissection is that you have the chance to adequately pathologically stage a patient, and you have the luxury of operating in a non-radiated neck. But however, this doesn't come without pitfalls, as it can cause treatment delay if your patient develops complications. And in terms of managing the unresectable neck, the options are either radiation without that chemotherapy and a salvage neck dissection for persistent disease or recurrent disease. In this randomized phase 3 trial, where they looked at PET-CT guided watchful waiting policy with a planned neck dissection in managing a locally advanced metastatic disease in patients with squamous cell carcinoma of unknown primary. They noted that the survival outcomes of PET-CT guided active surveillance were comparable to those of neck dissection, with fewer neck dissections, lesser complications, and lower cost due to reduced hospital stay. And this takes us to managing the violated neck. So in the past, there were reports of poorer prognosis in patients who had either excisional or incisional lymph node biopsies, but however, this has been eliminated with the adequate surgical and chemo radiation practices, and the P16 positivity of most tumors, which denote a sort of like a favorable prognosis. But however, if you want to manage a violated neck, the treatment is either upfront surgery with chemo with the adjuvant chemo radiation, or you have the option of a PET-CT surveillance with or without surgery if the PET-CT is at your disposal. Again, this brings us to radiation of the neck and the putative primary sites. This also remains a controversial topic. The question is, are you going to radiate the ipsilateral site versus bilateral radiation? And there's also a lack of prospective randomized studies in this perspective. And again, you should note that if you choose radiation as your primary modality of treatment, that's again introduce radiation for second primaries. And the other question is either to use a conventional external beam radiation versus the intensity modulated radiation therapy. So if you look at the external beam radiation, it has been shown to have superior survival results, but however, it doesn't come without complications. It actually has got more complications like intensity modulated or stereotactic radiotherapy. That is the pain, xerostomia, dysphagia, feeding tube dependence, and most patients requiring a gastrostomy feeding tube for up to a year. And then if we look at intensity modulated radiotherapy, this is sort of like a recent entity. and it is usually coupled with bilateral neck radiation. And it has been shown that it has got reduced toxicity and morbidity, and it is now the standard care of care in many countries. And it has also got improved mucosal coverage in patients undergoing total mucosal radiation. Frank et al. In a retrospective review of 52 patients in 2010 showed that the intensity modulated radiotherapy actually provides an excellent local regional control with fewer complications. And again, one of the largest experiences with reviews of cancer of unknown primary were the results of this Danish national survey, which was done by the Danish Society of Head and Neck Oncology. They reviewed about 352 patients over a 20-year period, and their 5-year estimates of neck control was about 51%, disease-specific survival of about 48%, and overall survival of about 36%, which is actually comparable to the other head and neck malignancies of which the primary is determined. And they showed also that, in 19% of the cases, there was emergence of the occult primary in a 5-year follow-up. That is, half of the cases, there was emergence of the primary in the head and neck region. And then in other half, there was emergence of the primary in other infraclavicular sites. So if we look at the images of the occult primary, there was, in patients treated with surgery only, there was about in 54% of cases, there was emergence of the primary as compared to patients who were treated with surgery and radiation therapy. And in these patients with surgery and radiation therapy, lower rates of images of primaries due to the radiation therapy involving the site of a suspected occult primary or involving a total mucosal radiation, which in any case radiates the area of suspicion anyways. And they noted that the nodal stage was the most important factor in neck control, with N1 disease having 69% rates of control, and N2 disease 58%, with N3 disease 30% control rates. And if they looked at the radiotherapy 5-year control rates and disease-free survival, they noted that with ipsilateral radiotherapy, they showed about 27% 5-year control rates and 28% disease-free survival. With the bilateral radiation, they showed about 51% control rates and about 45% disease-free survival. However, you should take note that this study was published in 2000, where the intensively modulated radiotherapy was not yet in. So all these patients were managed with external beam radiation, which comes with complications. So in conclusion, in this survey, they concluded that the cancer of unknown primary has got similar clinical features and prognosis to other head and neck squamous cell carcinomas, where the primary is detected. And there was lesser local regional failures of total mucosal radiation and bilateral neck radiation, with only a trend towards better survival. However, you should also take note that this doesn't, external beam radiation comes with its complications like cranial nerve pulses, radiation leukocytes, etc. Again, I thought I would share these latest guidelines of the NCCN guidelines on sort of like the algorithm on how to approach these patients with the cancer of unknown primary. So in patients who are presenting with the neck mass, you should do a comprehensive head examination. You prepare the oropharynx, you use either a mirror or fiber optic examination, and you examine those areas that are noted, that is the nasopharynx, oropharynx, hypopharynx, and larynx. And if your FNA shows that it's a squamous cell carcinoma, as I had alluded previously, the next step depends on the resources that are at your disposal. whether you have a CT scan available, whether you have got a PET CT available, whether you have got molecular testing available, etc. So this sort of like guides your next step in terms of the workup of your patient. But of note is that these guidelines, they don't necessarily apply to our African settings, taking into consideration that at times in other centers, they don't have head and neck surgeons, they can't perform pan endoscopies, they don't have access to chemo radiation, and they don't have access to P16 testing or other modes of molecular testing. So this is also another algorithm to guide in terms of your investigation based on the lymph nodes, the nodal levels involved. And if, for example, in terms of your management, if, for example, you find that your patient has got a squamous cell carcinoma and has got N1 disease, that is a metastasis in a single unilateral lymph node that is less than 3 centimeters, your options are either neck dissection or primary radiotherapy. This again depends on the resources at your disposal. If you've got the surgical expertise available, or you have got chemo radiation services available. And again, this is just an example to show if you choose neck dissection as your primary treatment modality, these are your options. If you've got N1 disease without external extension, you have the option to either radiate your patients, or you can actually have the option to observe with a sort of like employing a watchful waiting approach, where you serially see your patients every 1 to 3 months for the first year, and about 2 to 4 months for the second year, as any other head and neck patient. But of importance is this is unpublished guidelines of our African Head and Neck Society in terms of managing the cancer of unknown primary in developing countries and limited resource settings. For example, if you've got this is just an example. If you have got a nasopharyngeal endoscopy and only chemo radiation at your disposal, and you don't have CT, PET, or MRI, or neck dissection expertise, this is sort of the algorithm that you will follow. If you have got a confirmed SCC from cervical lymph node sampling, if your biopsy is diagnostics, these are your sort of like your options. It's either you can, because you don't have the expertise of neck dissection, so your primary sort of like treatment modalities will be based on what resources are at your disposal, which is sort of makes sense in our African settings where we don't usually have all these resources at our disposal. This is also another example. If you don't have chemo radiation services, you don't have imaging at your disposal, you only have nasopharyngeal endoscopy and neck dissection at your expertise. For example, you've got a confirmed SCC, you perform your full history examination, flexible nasal endoscopy, which is and you still you don't get sorry, if you after performing a detailed examination, your pan endoscopy is either it's normal, or you get a suspicious lesions that you either biopsy. If your biopsy is diagnostic, and then because you have surgical expertise, you don't have chemo radiation at your disposal, the options that you have is either it's a resectable tumor, either the primary or the neck metastasis, or it's unresectable. If it's unresectable, the only option that you have is either to palliate or you refer, because you don't have chemo radiation services at your disposal. So this is just two examples that I picked up in this unpublished guideline, which will be published, I'm sure, soon. And then if you look at the patterns of failure, they largely depend on your initial treatment protocol. And recurrence rates have been reported in up to 66% of cases, especially in patients who have been treated with surgery alone. And if external beam radiation is used, the recurrence is usually in the neck or with distant metastasis. And when these tumors recur, they are usually advanced with extranodal extension. And again, if PET-CT is at your disposal, it is probably the best method of detection and diagnosing recurrences. I also adopted this algorithm from Scott Brown. This is sort of like a simplified model. If you've got a patient with presenting with a neck node, you have to perform a comprehensive ENT examination. If you can't determine the primary site, you do a 5-minute aspiration to confirm the cytology. And then if that doesn't, if you don't confirm the biopsy from your FNA, the next step is to consider a biopsy, of which in our setting we usually employ a true-cut biopsy. And if your biopsy is EBV positive, you employ targeted nasopharyngeal biopsy. If it's a FNA and core biopsy do not indicate cancer, but the index of clinical suspicion remains high, you consider open biopsy as an oncological procedure. So we always prepare your patient for neck dissecting if you have to consider open biopsy. And then if you still can't detect your primary, you then employ conventional imaging. If you have access to a CT scan or MRI scan, with or without a PET-CT, it is at your disposal. And if you still can't pick up the primary, the next option is to book your patient for a endoscopic with a bilateral tonsillectomy and a tongue-based mucosectomy. And this basically leads to detection of primaries in more than 50% of the cases, which can then guide your management. So in summary, cancer of non-primary is becoming an increasingly rare entity due to the higher pickup rates of the recent molecular workup and cross-sectional imaging. So in the treatment, it depends on the stage and the institutional protocols. And combination therapy is basically used for advanced disease, and molecular analysis, that is your P16 and EBV analysis, may help to locate the primary tumor. And of note is that the survival outcomes for these patients are generally good. And these are some of the questions that remain unanswered. That is definitive neck dissection sufficient for patients with N1 to N2B disease, avoiding the need for elective total mucosal irradiation, or should a definitive radiotherapy with or without chemotherapy be offered as a primary modality of treatment with salvage neck dissection for persistent disease, or what's the extent of neck dissection should patients have for each stage? And what are the optimal fields for elective radiation? Do you employ ipsilateral radiation versus bilateral versus a total mucosal, unilateral or total mucosal bilateral radiation? And the last question being, is less intensive or single modality therapy adequate for the P16 positive tumor? So basically, these are some of the questions that remain unanswered. Thank you. That's those are the questions.
Thank you, Charles. That was really excellent presentation of a very, very controversial and a difficult topic, because as you noted, there are lots of different ways that people manage it. You see the NCCN guidelines that they give lots of options open in terms of how to manage things. And the other issue is how much money do you throw at the patient in terms of investigation before you say, well, you've done enough and you get managed it under primary. Just one point, you mentioned that if you're going to be proceeding to an open lymph node biopsy, you might as well proceed to a neck dissection. And I wouldn't quite agree with that, because you might still be sitting, because you're doing those in cases where your cytology is uncertain, and it could still be a lymphoma. It could turn out to be melanoma, where you want to stage a patient before you make a plan of treatment. So I wouldn't proceed straight to a neck dissection. I would first ensure that I get histology, and then maybe I can ask Julie or Samira. One of the areas which I'm also uncertain about is that how much do you have to pursue the possible invasive tongue tumor? Because if you're doing a mucosectomy and you pick up a small primary, if you're going to be irradiating that area anyway, and many of them are B16 positives, is finding that small primary that you can't necessarily detect just with random biopsies. Does it actually matter? And then the other issue is, should we be radiating the base of the tongue area in the under primary? Because during my career, then we progressed from radiating the nasopharynx as well as the oropharynx and hypopharynx to no longer including the nasopharynx because the mobility was just too high. So I very much like to hear from Samira or from Julie about those issues.
I don't know if Julie wants to go first, or should.
No, you go first, Samira. You go first, it's fine.
Thanks, Julie. So, yeah, thank you, Charles. That was a very good presentation. I must say, the longer I'm doing this, the more conservative I do become. And yes, I've also gone through that evolution for the unknown primary, where the nasopharynx was recommended in the initial textbooks and guidelines. I must say I never actually did that because I thought it was just too toxic for the patients, and probably because there were so few, I can't say that I've had any problems. I must say most of the time, depending on where the node was, you do get some radiation going to the base of tongue. So I wouldn't pursue it too much. I'm quite conservative with my fields. The few that has started out HPV positive, as Charles has pointed out, most of them do have a primary in the oropharynx. I also find that, yeah, one has to consider before you plan and start your radiation what the patient can actually, what they can actually tolerate. So I try and be as minimal with the fields as possible. Because ultimately you want not only minimal toxicity during treatment, but also in terms of long-term radiotherapy side effects, one wants to minimize that as well. So I think I'm quite conservative, but I'll hand over to Julie now.
No, I agree with Samira, and also I wanted to compliment Charles on his presentation. It was really very good. And very thorough and easy to follow. So thank you for that, Charles. I agree with Samira. Our patients, I constantly have to remind myself that our patients are not the patients that have been studied in a lot of the articles that one refers to or can find in the literature, because people present late in our setting. So you're not dealing with someone with a small lump in the neck who obviously becomes a little bit more complicated to treat, because you are balancing making the diagnosis and treating adequately versus side effects. We often see patients with very advanced disease. I'd say because they don't have a primary that causes symptoms, they often have node masses that are so large that they're ulcerating through the skin, and that becomes sort of really a lot easier to manage than a patient who's got very early presentation with an unknown primary, I think, anyway, because then you're dealing with a node that's so big that treating the contralateral neck, if the patient's well enough to be treated, as Samira pointed out, treating the contralateral neck becomes not that complicated, because we know that big masses or lots of masses and neck masses on one side, it is indicated to give at least, a low dose to the contralateral neck. The node mass is so big that the tonsil is in the field anyway. You would be very hard pressed to not treat the tonsil and even the base of tongue. So it becomes a lot easier in that setting. I think the complicated patients are the ones with a single node that's maybe only 2 or 3 centimeters in size, and you really have no idea where it comes from. That's where all these algorithms, come into play, and the imaging and so on, because you really have a much more complicated problem on your hand. So I haven't found them too difficult to treat over the years, because you've got a big mass and the patient's well enough, you give them chemoradiation and you end up treating a lot of the areas that the primary would have arisen from. Obviously, I'm not talking about skin cancers and things that have metastasized, but squamous carcinomas of the mucosal membrane. So the base of tongue is a little bit more complicated. If the node mass is a bit smaller, then you do have to make a conscious decision to treat it. And I must say, I have not done that, consciously over the years, try to treat both tonsils as individual organs and then the base of tongue in between. It's generally the tonsils that I've focused on. But as Samira also pointed out, that does mean that you get probably a low dose of radiation to the whole base of tongue, almost all of it anyway. The prophylactic dose, as we call it, of radiotherapy, of radiation in the treating head and neck cancers is quite low, according to the sort of more European and British standards. They tend to treat a higher dose in the States, but I tend to use the low dose. So if you consider that around 46 to 48 gray is possibly adequate for, or probably adequate for, subclinical microscopic disease, you may well be treating a lot of these patients anyway, just by treating, the tonsils and the adjacent nodal mass. I'm not sure if that makes any sense.
So Julie and Samira, so you're saying really that that you only really consciously treat the base of tongue if there's evidence of disease there.
Yes, well, I can only speak for myself. So I tend to include the tonsil because it is right next to the node mass almost always. But I don't consciously go out and treat the whole of the base of tongue. Okay.
Samira, would you agree with that?
Yeah, I would agree with that. As I said, I'm very conservative. So I try and minimize the radiation fields where I can. And only if I really thought there's any sort of suspicion about the area that I would treat it.
Yeah, because essentially what you're telling us as surgeons is that if you only going to treat the base of tongue consciously if there's evidence of disease, we should really pursue making or excluding disease in the base of tongue. And that's where the whole issue of a mucosectomy comes in. How far do you go with your actual trying to exclude disease in the base of tongue from a surgical perspective?
Can I just mention one thing about unilateral versus bilateral treatment? So we know that with the base of tongue, it's mandatory to treat both sides of the neck anyway. So that is why the base of the tongue for me is the most controversial area, if there is an occult primary there. If you have an occult primary in your tonsil, we know that there is a low, sort of a 10% incidence of contralateral disease, but it is listed as the sort of one part of the oropharynx that if you truly believe that there's no involvement of the base of tongue and or the soft palate, you are correct to only treat one side of the neck. And an occult primary of the tonsil falls into that category because it's so small that you can't even see it. So there's obviously not involvement of the soft palate or the base of tongue. So then, that whole thing about only treating one side of the neck becomes a little bit more justifiable. Obviously, if your occult primary is in the base of tongue, you could be making a mistake by not treating the opposite side of the neck, because that would be standard of care if the primary was evident.
Any other comments? With Kenneth or Millicent, do you want to comment?
Yes, good morning, Prof, and good morning, everybody. This is Kenneth. Thank you, Charles, for a comprehensive presentation. We, in essence, don't see too many of occult primaries, primarily just because, like Julie alluded to, our patients come in with quite advanced disease, almost ab initio. But however, once or twice, we stumble on patients who, having gone through FNAC, end up being inflammatory lesions, for which reason they are treated with antibiotics and they do well. But then when you get the profile as elderly with all the risk factors, then you go along the algorithms similar to what Charles presented. So we are conservative in the sense that because of cost implications, sometimes we try to go through all these FNAC, then you image and then do an FNAC. And then when we try to do P16 for especially those with lateral neck masses. Otherwise, our nasopharynx has quite a high yield when we do endoscopic biopsies. So even if it's a negative initial biopsy, we would then send the patient to theater and rather scrape the whole nasopharynx and send for histology. And we have a higher yield in this cohort of patients. Then, having said that, I think I agree with what other speakers have said and Charles' presentation. Thank you.
I don't see any more questions or raised hands. Thank you, everyone, for joining this morning's presentation. And as I close this presentation, we will meet again on Friday at the same time for our Friday blend on morning talks. Thanks once more for joining, and thanks everyone for the contributions made. On that regard, I will end this presentation. Keep well and safe.